Dr. Limakatso Lebina from Africa Health Research Institute Clinical Trials Unit will be presenting a session on the major challenge of missing TB cases, as well as the impact on current measures to fight TB in South Africa and the rest of the continent. Dr. Lebina joins us now to talk a little bit more about this. A very good evening to you, and thank you so much for speaking to us. Let's just first start with whether or not you've made the presentations, and I'd like to start with what you mentioned, one of the major challenges being that of missing TB cases.
Hi, thank you, and thank you very much for the opportunity and for chatting about this important topic, at least in terms of those affected by TB. The presentation is still to be made on Friday, but there have been several presentations during the conference that talk about finding the missing people with TB. There has been quite a move in the last few months that we need to use the correct words. There's a word press out there on what appropriate terms to use for TB related issues, and one of them is that we need to move away from cases and talk about finding the missing people with TB. But yeah, there has been a few talks on that and what can be done to find these people.
And I'm wondering, what are the categorical variables if we're talking about the challenges in terms of the gaps?
Yeah, one of I think the gaps that has been observed is that quite often a lot of the TB programs, not just in South Africa, but in many countries, especially in Africa, we are more concerned about what happens after we know that you have TB, after you've been diagnosed with TB. And that's when we start talking about offering free TB treatment, following up people to make sure they complete TB treatment. But there's a whole other things that have been missed prior to being diagnosed with TB. For example, in South Africa, TB treatment is free, but getting a TB diagnosis can be quite costly to the person affected by TB because it often involves multiple visits to a healthcare provider or service provider. That might include even costs of transport, and until that diagnosis is reached. It also affects the family negatively because sometimes it takes time because it's often not an easy illness to diagnose. And we're also starting to change our understanding about some of the indicators of who actually has TB. In the past, we used to talk a lot about the 4 classical symptoms that the World Health Organization recommended of a cough, night sweats or fever, losing weight. But now it's starting to show that there are people that might not have those classical symptoms yet have active TB disease. So we need to be more proactive as healthcare systems in finding these people with TB, and also using newer tools to diagnose TB and reducing the burden to the patient on seeking care for investigations, for a diagnosis on TB. And if we do not report on the number of tests done, for example, it will be very difficult to then understand where the problems are and how many people are actually accessing this test to be able to estimate if we are reaching all the people that should be investigated with TB.
So before we get to the diagnostic tools, I want to talk about the clinical and socio-demographic differences, the factors. What have we learned, at least over the past 2 years, especially during COVID-19, and just in comparison with over the years?
So what we've learned is that we used to talk about household contacts as one of the major people at high risk of getting TB. But we now realize it's not just household contacts, it's people who might have spent time with that person who's ill with TB. It might be in the workplace, it might be at school, it might be for recreational activities. So we need to start broadening our contact tracing, not just to include the household contacts, We've also learned that people that have had prior TB are at a very high risk of recurrence or reinfection or reactivation of the old TB disease. We're still not clear. But if somebody has had TB in the past, it's very important that they continue to be checked at least for the first 2 to 3 years to make sure that there's no recurrence of the TB. And lastly, we've also updated in terms of who are the key and priority populations or which people are vulnerable to TB, to also include people with mental health illnesses, disabilities, as well as adolescents. Quite often those are age group that we think they are well, but because of their behavior and their vulnerability to access health services, as well as their time in life where people are going out and spending more time with other people, they are also at higher risk of developing active TB disease. So looking at those age groups that are at high risk and what best interventions can we put in place to reach them. And yeah, in South Africa and across the world, we also know that males are more affected by TB than females, and this might be related to other social factors as well, like higher prevalence of smoking, higher prevalence of alcohol use disorders among men, and lastly, not seeking health services in the same way as more women would do.
So just a quick one on enhancing the TB diagnosis through equitable distribution of diagnostic tools like expanded use of X-ray, the availability of gene expert machines, and the provision of microscopy for both diagnosis and follow-up TB patients. Are we getting that right, given the fact that there often is, unfortunately, inequity between rural and urban settings?
I think as a country in South Africa, we are getting that right very well. We are one of the few countries to adopt the gene expert testing, and it has been rolled out in all the provinces, all the laboratories have it. Although the results are available in about 2 hours in a laboratory setting, the challenges are that if you are far from the laboratory and the specimen is collected and you are in a rural area, for you as a patient to get the results, it can still be 2 to 3 days later. And that's where we also lose then a few patients to be linked into care, because as soon as we have more or multiple visits from the sample collection date to the date of treatment initiation, then you have some people not coming back to get the results. So there are also now more technological initiatives to see how we can increase the number of people that receive their results. We've learned a lot from COVID. We learned that the SMS notification system from the laboratory can work very well. And those are some of the strategies that are being scaled up within South Africa to see if you also been tested for TB. Can you get your results on notification on SMS to also remind you then to go back to the service provider or the clinic where you are tested to be initiated on TB treatment, or to maybe get the good news that you were tested for TB, but based on these results, you currently do not have TB and you do not have to go back to your healthcare worker and go queue again for another 2 hours to just be told those good news. So I think COVID had a lot of disadvantages, but in terms of epidemiology, health systems strengthening, and how can we be more prepared for dealing with respiratory illnesses. Okay. There are some good lessons that can also be applied for TB.
I wish we had more time, but thank you so much for speaking to us for the time that you have, Dr. Limakatso Lebina. Thank you very much. We're going to leave it there.